actually be online right now. I know you think it's AI, but this is electrolytes. And so in terms of electrophysiology, that is really doing electrical potentials. Different parts of the what you call action potential, the electrical signaling in a cell, is different parts are driven by different electrolytes. You might have encountered this figure back in the day in physiology books when you're still at school. But basically, I'll not go to details. There's a phase called phase 0, when eventually the channels on a cell open up to allow sodium to fly into the cells to depolarize it. That's called depolarization. That's phase 0. But then once the potential, the membrane potential has increased to a certain level, other electrolytes also get angry because now they are not comfortable. So basically, potassium starts to escape from the cell so that it can restore its resting membrane pressure back to 95, negative 95, negative 90. But then soon enough, calcium is like, hey, I was getting happy because the potential is getting closer to my nonce potential, which is negative, which is positive 120. So it starts to antagonize the outflow of potassium. Unfortunately, calcium leakage, calcium entry is regulated by time, meaning that these channels open up and close quite quickly, allowing now potassium to leak out in phase 3, which causes repolarization. And then sometimes the repolarization is too much that you end up overshooting. So with too much potassium leaking out of the cell and too much sodium still stuck in the cell. So then now the ATPase pump gets active to push back potassium into the cells and push out sodium. So this is basically the basis of the electrical signals that we measure in ECGs, that we measure in electromyograms when we look at muscles. You can also measure from the skin. Essentially, every cell has got some sort of potential on it, but the most rapidly excitable ones are the ones that are important here. We're talking about the nerves, that means brain, the heart, that means the cardiovascular system, and the muscles, which are involved in contraction and light. So these are the things that lead to a number of things. So you see PQRST is really the depolarization stage. Then this phase, which is flat here, is really the phase in phase 2 where calcium is flowing in this ST area. Then the T wave is repolarization stage where the potassium is getting out and trying to restore the membrane potential back to normal. So ultimately, with all those movements, you have a well-knit machine that looks after our body so nicely. But things can go wrong. And so what can go wrong? There are so many mechanisms by which things can go wrong. Some of them are heterogenic. And actually, I would say most of them are heterogenic because now we are in a situation where we are practicing medicine in complex settings on complex patients with multiple medications, some of which we don't understand in terms of adverse effects, some of which we don't care to understand and therefore cause harm, but also just the interaction between different drugs and diseases is leading to a lot of things. So for extracellular electrolytes like sodium, the changes are going to be in terms of gaining the electrolyte or losing it from the body, like in the case of poor intake, when you have hormones that are either increasing the uptake or increasing the loss. When you have medications that are altering the transit of these drugs through the body, and then some diseases indirectly affect electrolytes. For example, if you had heart failure, for example, just by failing to deliver blood to the kidneys, will trigger the kidneys to start activating the RAS, the renin-angiotensin aldosterone system, which retains sodium, retains water, and in the end expands the blood volume, causing issues with sodium, among other things. Changes in the fluid status, like in the case of increased water intake, I've seen a number of young people these days walking around with big bottles of water. And right here in this room, Jimmy, Chief, has a big bottle of water in front of him. Increased intake of water, for example, will expand your blood volume too much, deliver too much fluid to the kidney, and the kidney filters it off. But because of the rapid flow of filtrate, you're going to be washing out electrolytes from your kidney. The consequence is that the concentrating ability of the kidney for fluid and electrolytes is depleted, leading to electrolyte imbalances. So honestly, sorry to say, but we're seeing many people with very beautiful skins because the dermatologist says take a lot of water, but they are increasingly damper because they are not retaining sodium, which is essential for neurotransmission. Hormones, drugs, disease influence of fluid as well. For intracellular things, on the other hand, remember, drugs that are extremely concentrated inside the cells are in large quantities. So that means if there's a change in the blood levels of these, for example, when there's a change in potassium, the first issue is something happened to do with its stay inside the cell. So usually cellular shifts are the leading causes of, say, an increase in potassium outside the cell. We shall go into the details if we get a moment with time. So cellular shifts due to diseases like diabetes, cellular shift due to drugs like insulin, like salbutamol, cellular shift due to hormones, can all influence electrolytes, while excretion challenges can also be a problem for intracellular electrolytes, like in the case of renal dysfunction. The case we just had was one of a patient with renal failure. So that means this patient was not able to excrete the potassium from their body, and that upset the balance between the intracellular and extracellular levels. But also you can have GIT losses of this, for example, in case of diarrhea and vomiting. And finally, again, medications can alter the excretion or reabsorption of certain drugs. For example, if a patient is taking drugs like spironolactone or ACE inhibitors or ARBs like telmisartan in the case of the patient we had, this can impair the elimination of potassium, for example, from the kidney, and that results in an increase in the blood levels. They can also affect the acid-base balance, for example, in the case of, again, ARBs, mineralocorticoid antagonists like spironolactone. They can cause a renal tubular acidosis, which eventually leads to hyperkalemia as well. So again, so many things can lead to dysfunction. Mr. Mawien Arik is already asking me, what volume are you referring to? Isn't it 2 fluid? Isn't it 2? Sorry, what was that? So I'm talking about the total blood volume, total body water balance. Remember, all the water you take in is distributed between the intracellular compartment and the extracellular compartment. And the extracellular compartment is broad. It has got the interstitial as well as the intravascular compartment. And when we talk about the intravascular compartment, we're talking about the components in the blood vessels, and we're talking about the component in the lymphatic circulation. So any change in the fluid anywhere will alter fluid somewhere, and eventually it gets rebalanced. That normal saline you give a patient, if you stop it from being excreted, that water will be distributed across based on the tonicity of the different compartments. Unfortunately, today is not a conversation on fluid, but it is essential here, because if I end up increasing the total body water in a higher concentration than the amount of sodium I have, I'll end up causing hemodilution, dilution of electrolytes, and sodium will be diluted. If I deplete water from the body in a way of dehydration, similarly, I will affect the concentration of electrolytes, particularly sodium in this case. So that's what I meant. Clinical presentation of electrolyte abnormalities are annoyingly non-specific, and they're not even sensitive. There are a few things that we have seen, but even then eliciting those signs is not very reliable. So when we talk about hypocalcemia and we talk about Vostek sign, truzos, and so on, fasciculations in the case of hypercalcemia and the like, and hyperkalemia, twitching here and there. These are all not very specific, unfortunately, and that is really the dilemma when dealing with electrolyte imbalances. So it is something that you have to suspect from the disease process the patient is presenting with, and look for any other clinical signs that could suggest it as a likely complication over some others. Some patients unknowingly and unfortunately present when they're already dead, while some will present when they are trying to die. Basically, they have they're in a cardiac arrest situation and need to do CPR. Maybe they will turn up in extreme organ dysfunction, and usually sometimes it's part of another severe disease. And unfortunately, this is really a common one. Patients come in, maybe they're septic, and then you somehow incidentally find that the potassium is elevated as well. But really, most of the clinical signs you're seeing are related to the other disease. So just understand this. Electrolytes are ubiquitous. They are essential. They are available everywhere. And so any disease that is in the body is likely to affect some electrolyte here or there. So only when you understand the pathophysiology of the disease that you are dealing with, will you put electrolyte abnormalities on top of the list. Some abnormalities present asymptomatically, and that doesn't mean that the level may be low. For example, a patient with chronic renal disease might present with no symptoms of hyperkalemia when the potassium level is like 6.5. You don't find any neuromuscular issues. You don't see any electrophysiological changes. And the patient is sitting there reading a newspaper, and then every now and again we get lab abnormalities of these electrolytes, which actually are false. For example, you have a very high potassium in a patient who has no signs of dysfunction that you'd expect of potassium in that setting. So for example, you have a patient who's got leukemia with a very high white cell count. You take that sample to the lab and the potassium comes back at 9, but the patient's heart rate is normal. Patient's ECG looks fine. The heartbeat, blood pressure, everything is okay. That is a factitious type. This is really because in some situations, you have extreme numbers of cells, and so potassium can leak out of those cells when they're in a test tube. Similarly, if you tourniquet a limb for a long time when you're drawing a sample, that ischemia to the limb can cause increase in leakage of potassium from the cells, increasing the levels. Again, if you don't run the sample soon enough, the sitting time the sample is having in the lab can lead to an increase in potassium, for example. So essentially, the idea is to figure out how to approach things emergently by detecting the abnormality. That's the first thing, detect abnormality quite quickly. And then you want to get help, because usually managing abnormalities of complex patients like this need more hands and more resources. So you want to get help quickly and start resuscitating that patient, depending on the stage where they're at. Maybe they're in a cardiac arrest situation, maybe they're in shock, wherever it is, start resuscitation, and then try to stabilize the primary abnormality. For example, it could be hyperkalemia, you want to stabilize them. It could be hypernatremia or hyponatremia, you want to work on that to stabilize the patient so that they are not dying anymore. Then only after then are you able now to focus on specific diagnostics and organ support that will give a patient a chance to get treated for the underlying cause, heal from the problem, or you find out, unfortunately, that it is, that you find out, unfortunately, that it, the disease, the underlying disease process is incurable. You may need to palliate the patient, unfortunately. So my simple approach to electrolyte abnormalities is you need to know there are 5 S's. That is to spot, which is to identify the problem. You need to save the patient from dying imminently by resuscitating them. And then you want to sustain life by providing organ support as necessary and stabilize the patient. In other words, the underlying mechanism is stabilized so it doesn't continue to cause problems to the patient. And then finally, you want to salvage this patient or palliate them. In other words, you want to render a cure to this patient's problem, the underlying cause of all this. Electrolytes are victims. They're like us, except that, a victim can sometimes turn to be a villain. Yeah. So that really, I would say, is my small cheat sheet around electrolytes. How to approach them. I would want to try to figure out the underlying problem the patient has quickly and try to rescue them from death try to stabilize them, try to go on investigating the underlying cause and treat it, rehabilitate the patient, and get them back out there. The problem is that there is a difference between knowing that stuff and actually practicing it. And I can see some questions coming through already in the chat. So I'll just use some few electrolytes, if possible. I don't know if I still have enough time, just to give an idea of how to think around a problem in an emergency. Remember, we're not discussing treatment of, say, hyperkalemia in the general ward as a nephrologist or as a as a kidney leaning doctor. That long-term care is not of interest to us. In the emergency area, we want to save life. I don't know how to put it, but we are the guys who save lives. Okay, so basically, potassium, as I've mentioned, is predominant intracellular. It was first identified in 1807, really from ash of potted plants. And later on, its functions and existence in the body were delineated. And of course, as I mentioned earlier on, it's predominant intracellular, plus extracellular, and it's micromanaged with a small concentration, meaning that the reduction of potassium below 3.5, for example, will cause a problem. An increase above 4.5 will cause a problem. And there's a lot of data out there in the literature to support that. So disturbances in potassium concentration in the blood will predominantly happen due to challenges with storage of potassium inside the cell. Because too much of it is inside the cells, it follows therefore that a blood level of potassium changing just means something's affecting its storage in the cells. For example, hyperkalemia will result from leakage from the cells outside. Hypokalemia will result from an increased uptake into the cells, depleting the concentration in the bloodstream. The next major factor leading to changes in potassium to do with the elimination from the body. If you increase the elimination from the body, be it from a GIT or from the kidneys, either through diuresis or disease process like diarrhea and vomiting, then for sure you're going to deplete potassium, partly from reducing the intake, but also from the homeostatic adjustment the body will make, because the body will try to save sodium at the expense of potassium. So the kidneys will excrete potassium in order to save sodium. That's part of what the RAS does for you when it's very active, to compensate for fluid losses. But if you have, say, failed kidneys, then they can't eliminate potassium, so it accumulates in the body. When you have medications that are altering the excretion of potassium, like in the case of septrin, in the case of spironolactone, telmisartan, etc., then for sure you can't excrete it. The factitious component has to be highlighted here because it's very common for us to respond to a high potassium level in blood when that actually isn't the case, because somehow you sent off a sample to the lab yesterday and maybe the other day, and then you get the results today, and that sample has been sitting on the bench in the lab. And hopefully we have some lab personnel on the chat or on the group today. It's unfortunate that every now and again we've got people in the lab mishandling these specimens. First of all, they're mishandled by us, the clinicians bedside, because we draw the blood samples, we keep them by the patient's bedside, and then eventually take them to the lab. Then the lab also leaves them overnight. It's something that we have to improve, knowing that these are time-sensitive labs. So the approach, as mentioned before, follows the 5 S's. So let's look at hyperkalemia. A patient with hyperkalemia, again, as I mentioned, will present with very non-specific signs. There are very few signs that you could claim as specific to potassium, but really the diagnosis clinically is a diagnosis of exclusion, but you can increase your diagnostic pretest by considering other parameters. For example, you have a patient who has not been passing urine for a number of days. He's coming in drowsy, weak, and twitching, and he has got a slow heartbeat, and the EKG shows tall tentative T waves, and so on and so forth. Then for sure, it increases the likelihood that this could be hyperkalemia. But you cannot just pick out any of those signs and swear that that's potassium, because there's so many things that can change the ECG. There are so many things that can cause twitching of the muscles and parathesias. There are so many that can cause irritability. So it is a game of trying to put multiple signs together with the history and physical of the patient to actually try to suspect highly. Reliably, you might have to perform labs. That's really the one way you can get it. So perform your lab tests, look for potassium in your electrolytes. But because potassium doesn't go alone, you want to look at its balance with the other electrolytes, as we mentioned in the other graphic I talked about earlier. So you want to know the sodium, magnesium, calcium. But then because magnesium, because potassium is predominantly excreted by the kidney, you want to look at the creatine and urea as well. Yes, then you can now look at other contributors. For example, what is the CBC saying? Could it be the explanation for the high potassium? For example, the patient's hemolyzing, and shedding out potassium. Could it be the patient be having an increased white cell count due to leukemia? Could the patient have been bleeding because they are it's a low platelet count, and so they are going into hypovolemic shock and got kidney disease? ECG can be helpful where it's available because it gives you a clue to the electrophysiological changes, and there are multiple. But in the absence of ECGs, like is the case in many of our workplaces, potassium in high levels in blood affects the depolarization of cells. And that means it slows down depolarization. So you're talking about a patient who has got a slower heartbeat than you expect for their level of illness. The patient has got a fever, 39 degrees, you expect their heart rate to be like 120. But this guy's heart rate is just taking its time. It's chilling at 80, at 70. It doesn't look bad by itself, but relative to the disease presentation at that point, it's really bad. A patient has got maybe hypotension. Those are some of the clues, that something is wrong with this patient and could be actually hyperkalemia leading to it. On the other hand, the rest of the signs may not be very helpful. Then you can also look for signs suggestive of the underlying cause. For example, could there be things suggesting an increased shift out of the cells, like a patient might have a tumor, patient has bucket lymphoma, for example, and they have just recently had chemotherapy. So they are having what's called tumor lysis syndrome. So they are shedding too much potassium from the cells. Could they be having hemolytic disease? So they have had a blood transfusion recently. Could they be having rhabdomyolysis, for example? They have been involved in an accident, so they crush their limb, and so there's dead tissue somewhere. It's a compartment syndrome. So those are some of the things that can help you. This could be a potassium problem. But unfortunately, looking at just the clinical signs may not be very helpful. ECG signs are also very unreliable, unknowingly. I know that guys are really desperate to hear what the ECG changes are in hyperkalemia, for example, but unknowingly, they are not very reliable. And especially in chronic cases, some patients can have a very high potassium level, but there's no ECG change. So again, you look at the electrophysiological effect of high potassium on depolarization. You have some guy whose ECG somehow looks okay, but the guy's heart rate is slower than is expected. That is a clue to you that something is wrong. Yeah. And then, of course, in the end stage, potassium can lead to, arrhythmias and particularly cardiac arrest rhythms like ventricular tachycardia and ventricular fibrillation and systole. And many patients don't get diagnosed because they die before we get a chance to lay hands on them. And some we lay hands on will not even recover because you don't suspect hyperkalemia, and so you don't do the appropriate interventions. So the approach to save and stabilize this guy is airway breathing saturation. It's an emergency. It's always going to be A, B, C, D, E, F. I do not care how beautiful your medications are, where you've studied, my dear friends. If you do not do airway breathing saturation disability, and do not ever forget glucose, EFG, a Foley catheter in there, I promise you, you're going to lose the patient. Because hyperkalemia itself, for example, can cause the cardiac arrest, but the disease process itself causing the hyperkalemia can cause instability. So you need to first save life before you start, talking of hyperkalemia. So if the patient has got severe hyperkalemia, this is usually taken as a figure above 7 millimoles per liter, or any hyperkalemic figure with evidence of ECG changes or electrophysiological disturbances, cardiac arrest, arrhythmia, PVCs, multiple of them, and the shock. That is severe. That patient needs you to stabilize the heart. I'm going to use the basic word that we use on the street. It says stabilize the heart. And stabilizing the heart is done by administering a new drug, a new electrolyte that is not interfered by the sodium potassium ATPase pump. In hyperkalemia, what will happen is that because of the high potassium, the cell membrane becomes insensitive to sodium entry. So it can't depolarize anymore. So you want to re-establish a membrane potential that allows sodium channels open so sodium can go in. So calcium salts are quite a quick way of doing that because they are doubly charged and you administer them rapidly to a patient. They go in, they increase the extracellular positive charge, relative to the intracellular positive charge, and that re-establishes the membrane potential. That allows the sodium channels open and sodium can go into the cells. Additionally, the calcium can flow into the cells with calcium channels and therefore induce sodium to escape from that cell. On top of that also, is calcium also activates a number of other processes into the cell which lead to dislodging of potassium from from the areas, allowing it to reestablish activity of the different channels. So initially, that is what calcium does. It does not reduce the potassium. It just helps to restore a membrane potential that allows the action potential to be propagated so the cells can depolarize. So now that allows the heart to beat. That allows the arrhythmias to disappear. That allows you to perfuse tissues. Now that you have saved life, next part is to try to shift away that potassium from the extracellular space into the intracellular space. You're buying, you're renting space. You're saying, hey, I need to push this potassium back into the cell for a moment because I know eliminating from the body, which is the ultimate, is going to time. Diagnosing the underlying cause that led to this is going to take time. Let me just shift it into a rented space called intracellular space using drugs that increase the intracellular shift. For example, if the patient is acidemic, you can give sodium bicarb. We know that wherever hydrogen ions go in acidosis, potassium follows. So you want to give bicarb to neutralize the acidity so that finally potassium can go back into the cells where the hydrogens came from in the first place. Insulin is commonly used, and you want to give a good dose of insulin, about 0.1 units per kilogram of insulin, or 10 units per dose in adults. But we know that insulin causes hypoglycemia, so you want to avoid hypoglycemia because hypoglycemia kills. So you want to give insulin along with the glucose. And then salbutamol. In the case that was presented to us, salbutamol was given at 5 milligrams per dose, which is extremely low. The idea is that you want to saturate the beta receptors of the body with salbutamol so that they can hyperpolarize and suck in potassium into their cells. So you want to use skeletal muscles, you want to use skin cells, you want to use all the cells of the body to actually take up this potassium. That's the idea of salbutamol. So in the higher dose, in fact, it's recommended to use 5 times the dose for nebulizing for asthma. So if you usually use 2.5 to 5 milligrams of salbutamol for nebulizing patients with asthma, you need about 12.5 to 25 milligrams. The patient will shake like a leaf. They will hate life. Their heart will beat like crazy, but celebrate. It means it's working. Okay, so that is the idea. Unfortunately, a dose of insulin, for example, dose of salbutamol will only reduce the potassium by about 0.3 to 0.6 millimoles per liter per dose. That means if the potassium level is really quite high, you're only buying a window of opportunity to initiate excretion means. That means the patient has some residual urine output. You need to enhance it with a diuretic, and in this case, we're using a sodium-sparing diuretic or a kaliuretic diuretic. In this case, we're talking about a loop diuretic. So you use furosemide, for example, it's readily available. You give a large dose of it. What it will do is it will block the potassium and sodium reabsorption from the loop of Henle, deliver into a distal tubule from which so much potassium will be eliminated in a way of trying to save sodium through the sodium, hydrogen, sodium, calcium, potassium exchanges in the distal tubule. So that is how you can eliminate potassium quite rapidly. However, if you give a patient a good dose of diuretic, so I'm talking about really quite high doses, and you can go all the way, depending on the renal function of a patient, you can go all the way up to like 200, 240 milligrams of Lasix. And if the patient doesn't respond well to that, then it means they will not exactly excrete. So you need to go to the next measure, which is dialysis. Now, the Lasix dose you give may lead to fluid depletion as well. So you may need to be doing what you call euvolemic diuresis, where you're measuring the urine output and you are replacing that volume. In other words, if per hour the patient is losing about 100 cc of urine on the loop diuretic, you want to be infusing back 100 cc of crystalloid, and particularly we're talking about a balanced solution, like particularly ringas lactate. The reason is that you might need a large volume of this fluid for volume expansion, and if you're using normal saline for a long time, the chloride will accumulate and cause metabolic acidosis, which will again cause more potassium to leak from the cells. So ringas lactate, on the other hand, does not worsen potassium because it doesn't worsen acidosis. Dialysis can imagine to be acquired. Now, depending on where you are, I've seen a question where someone is asking what to do when you're in a health center 3. You should refer. This patient is too sick for that place. You know, health center 3 is for treating simple ailments, diagnosing or screening, and transferring to a place where a patient might be able to be cared for, because it's not just potassium is a red herring. It's telling you something is wrong with the patient, and this patient has got a multi-system issue, which could potentially be deleterious. You need to get them out quickly, you know? So don't spend too much time. The moment you suspect a patient could have acute kidney injury, a patient could have hyperkalemia, whatever it is, you need to refer them where they can be diagnosed, where they can be treated quickly. Resins, like Kawempe, can be given. However, in acute settings, it is really quite questionable what their role is. And I would probably not waste time trying to administer them, because you give a very large dose per day of this medication, and the drop in potassium is quite minimal. I'm talking about 0.3 millimoles per liter drop of potassium, you know, per dose, you know, and you know, it's just dirty. So I would probably avoid resins in the acute period. They are more useful in the chronic stage because you have to establish that the patient's gut is actually working and can absorb it and transit it through from the mouth all the way to the anus. Otherwise, the sorbitol that comes with Kawempe, for example, can be harmful in terms of causing colonic necrosis. So we cannot discourage it. It's not a major worry, but it's discouraged because it's not very effective. But in chronic stage cases where a patient has been stabilized by dialysis, it can be used. If a patient has got a risk of fluid overload, Kawempe is sodium polysulfonate. It has a lot of sodium. So what it does is it's taken into the gut, and from the colon, it exchanges the sodium for potassium, so that sodium is absorbed while potassium is lost in the stool. The problem is that if a patient is hypervolemic, that sodium can cause volume expansion. So there's another type of resin called the calcium resonium, which has calcium. So in that case, calcium will be absorbed in exchange for potassium, and good enough calcium can also help us with hemodynamics and stabilizing the cardiac membrane. There are newer resins like Pathophysiology and zirconia that can be used. But again, this phase of resins is really a late introduction after the patient has undergone dialysis and so on. So by this stage, you should probably have referred this patient now maybe to nephrology, to intensive care unit. They have been stabilized and now they're about to go home. So we place them on resins to just sustain potassium excretion in patients whose renal function hasn't improved enough yet. Salbutamol, people ask about salbutamol. Salbutamol is a beta agonist. It's particularly beta 1 and beta 2. Beta 1 receptor stimulation causes your heart to beat fast and stronger. Beta 2 causes vasodilation, but it does so by taking up potassium. When the receptor is stimulated, it increases the potassium uptake into those cells. So that is how potassium is taken up when you give a patient a large dose of salbutamol. That's why you might have witnessed that a patient who has got asthma in your clinic, when you gave them salbutamol, they started shaking, because when potassium reduces, the cells start to twitch because they cannot depolarize it properly. And similarly, that uptake of potassium can also, in the pancreatic islet cells, which have beta receptors, can lead to release of insulin. So it can now serve the other function of insulin as well, by increasing the insulin levels and therefore uptake. That's again why you have to be watching for glucose and so on in these patients. So ultimately, the cure for patients with hyperkalemia lies in finding out the cause, the mechanism, and treating it. So if it's cancer, please treat the patient. If it's renal failure, palliate and support the patient. If it's a GI bleed, handle it. If the patient had a transfusion, monitor it closely, because eventually it'll be cleared out. So that's really what you have to do. But in the process, you want to be supporting the organs, make sure they are safe. And this means that in the emergency room, you're not be able to keep the patient for long. So you may have to contact ICU for a bit of intermediate care. And depending on the underlying cause, if a patient has got, say, a compartment syndrome, you might want to call surgery to provide a fasciotomy. If a patient has got abdominal compartment syndrome affecting their kidney function, you might want to take them to general surgery, among other things. So there are multiple consults you have to do, because again, like I said, hyperkalemia is nearly a red herring, telling us it's a major multi-system problem in the patient. Your job in the emergency room is save life, stabilize, start investigations, consult, and eventually dispose of to the right units. Hypokalemia is not exactly the opposite, but kind of close. Again, the clinical signs are not specific, just like hyperkalemia, but basically you're talking about a person whose potassium level is low, and therefore their excitable tissue not able to depolarize quickly and to repolarize quickly. So that means they will struggle to depolarize. So initially they might be bradycardic, but eventually they become tachycardic, and that is usually the source of arrhythmia. So most of these patients present with abnormalities, first of all, in muscle conduction, so they tend to be weak with a bit of paralysis. They have ileus, the intestine is paralyzed, and they're lethargic. And then because muscles cannot contract nicely, they breathe faster. The first sign of neuromuscular weakness is tachypnea, because you can't inflate your lungs enough. You have to breathe quicker to maintain the volume of breathing. So these people will be breathing in a quick, shallow breath. But ultimately, if you're to put an ECG, you might see some ECG changes on them, like a prolonged QT, you've got a depressed ST, tiny T waves, and maybe you might be able to see what's called U waves. You have a bump called a T wave, and there's another bump following it, which is called a U wave. It says U wave, and you'd imagine that it's inverted. No, the U wave is a positive wave. It faces upwards, not downwards. But kindly Google it up, because you might not have enough time for it. But unknowingly, unfortunately, these patients tend to present when they have arrhythmias already, and some of them in cardiac arrest. And so again, the approach to treatment is airway breathing circulation, among other things. And then when you have stabilized and saved their life, you can now stratify and find out, was the patient having severe hypokalemia, in which case you want to rapidly correct it with KCL in this case, by giving bolus of KCL until the annoying complications stop. In other words, you're having arrhythmias, you want to give boluses of KCL or about 5 to 20 millimoles every 15 to 20 minutes until the arrhythmia stops. Then you can now repeat the serum potassium level, and then assess the deficit of potassium from there, and proceed to choose a source of correction. If the patient's gut is working well, in other words, they don't have ileus and not vomiting, and they can tolerate it, you give the oral route is preferred, because again, potassium, remember, potassium is used on death row. Those bad politicians we don't like, If one day you take them to, to Luzira for corruption and they are on death row, it will be KCl that will be used. So if you administer potassium chloride intravenously, you have to regulate the rate so much. Otherwise, if it goes in too fast, the rapid correction, even just from 5 to 2 millimoles per liter, can be enough to cause a cardiac arrest. That's a problem with potassium. So it just be given quite slowly as an infusion. So you dilute in a large volume of fluid, like in normal saline, and then you infuse it slowly, to correct it. Then you keep checking the amount, just make sure that the patient is safe. If the patient is stable enough, please give oral route because the gut will regulate how much it absorbs. So you avoid the risks and complications of intravenous use. KCl is highly ionizable. It's an ionic compound, so inorganic compound. So it is highly ionizable. And since the ionizable in the case of potassium means they induce depolarization within the vessels, and therefore they can irritate the vessel by causing activation of pain receptors. So it really hurts so crazy to, it hurts like crazy when you're infusing KCl through a peripheral vein. So most times when you want to give KCl, it's recommended that you use it, you put it through a central line. But you can still give it through a peripheral line, except that you have to dilute it significantly. So we're talking about putting like 40 millimoles in 500 mils of normal saline, and then you infuse it slowly. There, the irritation to the vessel may not be significant, but make sure that the vessel you've chosen is quite a big one, like vito fossa, and you have a large cannula which is well secured to avoid extravasation, because extravasation also can cause pain. Yes, so if the patient has got maybe hypophosphatemia as well, then potassium phosphate may be better. If the patient has got acidosis, then maybe potassium bicarb or potassium citrate may be more useful. These are the different preparations available, and some of them are in our market. I think potassium phosphate and potassium bicarb are not in our market, but potassium citrate and potassium chloride are in the market. And potassium citrate particularly is available as tablets as well. So these are things that you can use. Again, as long as the gut is working, use the gut. The deficit is usually huge. A drop, remember, potassium is predominantly intracellular. So when you see a slight change extracellularly, it means there's a huge deficit in total body sodium. By the time it was able to drop from about 3.5 to say 3.2, that's a 0.3 millimole per liter drop. That means you have a deficit of 100 millimoles. That means when we start correcting potassium acutely, we normalize the blood levels. But then we have to continue giving oral correction to correct the deficit of potassium later on. So don't just say, I've given KCl 40 millimoles, potassium has gone up to say 4 millimoles and you're happy. There is a transit time between potassium appearing in the blood and potassium shifting into the cells. That half-life is about 2 to 4 hours. That's why when you've corrected potassium in a patient who's hypokalemic, it's not recommended to check the levels within a few minutes of infusing it. At best, wait for about 2 to 4 hours to allow for the transit of that potassium into the cells to give you a good reflection of the blood level of potassium. That way, you don't call off your aggressive care too quickly. Yeah, and then of course, ultimately treat the underlying cause and get the patient to the right place where they belong. I feel like we're approaching a lot of time. They of course are the electrolytes like sodium and so on, but I think we can talk about them in the discussion so I don't take up most of the afternoon. Thank you so much.
Wow, thank you so much, Dr.
Erasmus Okello, for that
comprehensive
presentation.
Approach to the patient with electrolyte imbalance.
Very informative. It has been very informative, and I know it has triggered a lot of questions in the audience. So I'm going to allow 2 questions for now from the audience, and then we shall proceed to have the presentation from Mr. Ssemwanga about
Moderator, I see there are some questions we put on the chat. Maybe us wait for the ones who are unmuting. Is there someone unmuting?
Hello, team. We are welcoming 2 questions. If you have a question, you could raise up your hand. We pick you up so that our expert can answer the question before we go into the next presentation. You can just raise up your hand, and then I'm seeing Mawin Arik raised up his hand.
Yeah.
Please go on and ask your question.
Yeah, thank you so much, Doctor, for the presentation and the knowledge. I just want clarity regarding the comment you made with somebody with water in front there. I couldn't see. So what is the normal volume recommended daily intake for a person without heart or kidney or liver issues? Because you made a comment that taking a lot of water may cause derangement in your electrolytes. But what volume of water? I think that's what I wanted to find out from
yeah, excellent question, Mawen. Thank you
you
so much, Mawen, for clarifying now. You've got a very efficient, intelligent policeman of the water that you're supposed to take. In your brain, it's called your hypothalamus. It instructs you on how much fluid to take because it is constantly reading the concentration of electrolytes, the concentration of solutes in your blood, the tonicity of blood. And by so doing, it's able to determine whether you need to dilute a little bit by taking some water or you need to wait. So listen to your hypothalamus. In other words, respect your thirst. When your thirst tells you to take water, take water. When your thirst stands off the thirst and says this is enough, stop. Your kidneys are very intelligent because the nephrons know how and when to adjust and increase the water retention. Let us not try to be more intelligent than something that is nicely woven by a beautiful thing called evolution, or in the case of Christians, God. Your body is so intelligent and can regulate. Now, if you have a disease process affecting your ability to sense thirst, it can happen in people who have got brain disease, the elderly people, people with dementia, children. Unfortunately, in that case, we have to estimate what they need, and we use certain formulae for calculating or estimating the daily fluid requirements of a patient. Again, a conversation on fluid and electrolytes, fluid physiology would be very helpful, future date. But basically, we're talking about, on average, most 70 kilogram adults might be requiring between 2.5 to about 3 liters of water a day. That's why people come up with that. But unfortunately, it causes a lot of dogmatism, that people now walk around wanting to carry 6 glasses of water everywhere. Then some find another interest. They want to walk around and maybe carry even more water, because telling them 8 liters, 10 liters of water. For Christ's sake, where is it going? You only have 5 liters of blood volume in you, you know? Now, where are you putting this extra 5 liters? What are you doing to your body, you know? So your body is quite intelligent, and it instructs you on when to take water based on your thirst. And as long as you have a healthy hypothalamus and relatively healthy kidneys, listen to your thirst and respect it. Thank you, Mawen.
Yeah, thank you so much, Dr. Erasmus, for that excellent response. Maybe the other question to look at here, there's someone in the chat who asked, when you have a patient with, for example, multiple myeloma with already high calcium and they get hyperkalemia from maybe an AKI, should we give them calcium gluconate in case of ECG changes? And should we give it anyway in that case? Yeah, they are concerned about whether they should give calcium gluconate.
Again, very good question, and I see people have been reading, which is quite great. Now, one of the few areas where calcium is discouraged, although theoretically, is in areas where the phosphate level might be high, because the fear there is that this patient might have might develop what called metastatic calcification, where the calcium and the phosphate react, and the calcium phosphate deposits happen all over the body, in the microvasculature of the brain, heart, lungs, kidneys, everywhere, and worsen things. In the case of our hypercalcemic, when they come with hyperkalemia, if they are having severe symptoms that you can ably link to hyperkalemia, in other words, they're having bradycardia, they're having a wide QRS with tilted T waves, they've got depressed flat P waves, and they're maybe going to wide sinus VF. Give calcium. Okay, the calcium that you get through multiple myeloma tends to also be it tends to be chelated with a number of proteins that are floating around, as well as phosphate that's coming from the bone breakdown. So what you're looking for is ionized phosphate, which is going to be readily available to interact with the cell membrane to stabilize it, and that may be the problem with the kind of patient. However, remember, the first intervention in hyperkalemia, regardless of the mechanism, is airway breathing circulation. Then provide volume expansion. People who have got multiple myeloma tend to be volume deplete because the calcium itself is a diuretic. So they are dehydrated. They need volume expansion. And with that volume expansion, ultimately, that causes hemodilution, including the potassium itself gets diluted. So by the time you repeat the assessment of the potassium level, you might find that it has actually dropped after the volume expansion to a fairly appropriate level where you don't even need to use calcium. Now you need to think about, do I enhance the elimination? Do I first shift before I do it? Do I just go for dialysis because we have renal failure? That's the idea.
Thank you so much, Dr. Erasmus, for the great response. Yeah, there's a lot to learn here, and we are going to have Dr. Erasmus after the presentation of Mr. Ssemwanga Edrisa, who is going to take us through the nursing care of a patient with electrolyte imbalance. Ssemwanga Edrisa is a nurse in charge of Kawempe National Referral ICU, and is going to take us through the role of a nurse in management of electrolyte imbalances. You're most welcome, sir.
Thank you very much, the moderator and the previous presenter. You have really done a wonderful job that you have almost left me with not much to say, I should say. But as they've already introduced me, I don't need to go back and reintroduce myself. But let's dip into the presentation. So let's go to the second slide, the next slide. So as we are looking at our electrolyte imbalance, I think from Dr. Erasmus's presentation, I don't need to define what an electrolyte is and all that. As a nurse, basically you'll see that we are part of the team that is going to care for these patients routinely. And you realize that your patient will spend a lot of time with you as a nurse because there is a lot that you need to look out for. So in a part of our nursing care, for us to ensure that we care for this patient comprehensively, there is a component of what we call a nursing process that we shall use in managing this patient with electrolyte imbalance. So I would talk about nursing process in a view of the case that was written earlier. Then later on, we shall look at a few other components the nurse is supposed to look out for when it comes to the rest of the other electrolyte imbalances. And when we talk about nursing process, everything begins with assessment. So you need to assess your patient. You need to take good history if your patient is able to talk. If not, then you'll go in for the secondary sources of data, that is the next of kin, or any other person who has come with attendant, could even be a medical personnel. So in your assessment, you're going to take subjective data, and then you're going to do also objective data, which will involve your examination. And we have seen this is an emergency. We can go to the next slide. So this is an emergency. So that means you are going to do your ABCDEF assessment. Just a flash of the subjective data from the previous case that was read to give a component of subjectment to our patients. We can continue. Then, when we go to our objective data, we really need to do the ABCDE rapid assessment, because this is an emergency, so we shall not have time to do a systemic exam. So because we need to resuscitate the patient immediately, find out the problem and tackle it very well. So when we do our rapid assessment, we can link to the signs that were clear in the case that was read to us. But again, in this objective assessment, we also need to look at the investigations done, because they are very key when it comes to managing our patient. For example, the RBS, the CBC, electrolytes themselves, and we need to evaluate the evidence. So that is a simple classical picture about hyperkalemia, which I cannot again go back to, because Dr. Erasmus has elaborated more about it. So we can continue. So still that is giving you the ECG changes as a nurse that you should look out for when you are monitoring your patients. And in this regard, you also have to have the skills to do a 12-lead EKG, such that you are able to diagnose, because the one you're using for monitoring, where you put your patient on electrodes on the chest and then start monitoring, then you need to accompany with a 12-lead EKG to really diagnose and know what you're going to do with the patient. And these are the features that you're going to look out for on your EKG changes, the 12-peak T waves, as they are really being summarized. You're also looking at the prolonged PR segment. We shall also look at the loss of the P wave once we are getting up with severe levels of hyperkalemia. You will see the ST segment elevation, as it is well stipulated in the picture here. So in cases of severe hyperkalemia, that is when you're going to also get into these severe deadly heart rhythms, the ventricular fibrillation. And if still you're not doing anything to resuscitate your patient, automatically you'll get an asystole and you're already in a cardiac arrest where things have gone beyond bad. So you need to be able to detect this immediately, and then you initiate your interventions, but you work as a team. You don't work as an individual. Yes? So as a nurse, when we finish assessing our patient, we have taken our history, we have examined the patient, we have correlated with the investigations done, then we need to diagnose our patient in order to start management. So as we are diagnosing our patient, we have to ensure that we prioritize the concerns we have on this patient. These are concerns that are generated from the previous case that was written. And from there, you make a nursing diagnosis, and then you start ensuring that you manage your patient based on the priority diagnosis that you have set. But remember, for example, the patient we have in question with hyperkalemia, the potential complication is dysrhythmias. So you have to ensure that your management is targeted and timely. Yeah. So in here, when you're managing your patient, you have to have goals of care. So in these goals of care, they should be incorporated in your planning. So when Dr. Erasmus was giving his presentation, he told you about not immediately doing testing to check whether your patient with hypokalemia within less than an hour, you have collected your hypokalemia and you start jubilating. So you need to set realistic time goals when you're going to ensuring that you reassess your goals, whether you have achieved them or no. So for example, in this patient with hyperkalemia that we had, it's unfortunate that we lost the patient. One of the goals of care would be the client will remain with a serum potassium level that within the normal range, within, for example, 4 to 12 hours. So I believe that by that time of range, you have given enough time to start correcting the problem you have, and then you reassess with time. And then the other goal of care would be the client will remain in a normal sinus heart rhythm with a regular rate. Yes. So in this case scenario, so here we look at the specific nursing care when it comes to management of this patient with hyperkalemia. For example, the first thing is you're going to ensure that the treatment you're going to give this patient should be targeted. What are you aiming for in this kind of treatment? One is you're going to eliminate potassium. You're going to force potassium back into the cell, and we have already seen the mechanism. So the next thing here, you're going to ensure that in so doing, when you're eliminating potassium, you're going to give diuretics. And the choice would be loop diuretics to ensure that you eliminate your potassium. There is also some little science, as you've heard, about Kawempe, about eliminating potassium in the GI route, which is not so effective, but we have gone ahead to see it in our everyday practice. So here, the other thing is you're going to initiate the insulin dextrose as prescribed, but preferably this would better be given when you have infusion devices. That's why someone on very lower level settings, you need to refer this patient immediately, such that the hospital where this patient is going to be, they have all what it takes to manage this patient. However, when you're doing your insulin dextrose, you have to take note to monitor your RBS. As we shall see when it comes to critical care, the number of investigations that we have, number of vitals that we have added into or incorporated into the normal vitals that you may not find out of critical care. So an RBS is supposed to be done here on a regular basis to ensure that you don't send your patient into hypoglycemia. So then you'll also give your IV calcium gluconate to ensure that you avert the myocardial excitability and lessen the chances of your patient going exacerbating and reaching a cardiac arrest. So there's also a component of calcium chloride, but here you have to take note on to how you're going to administer these drugs. For example, calcium chloride, preferably you would not give it using a peripheral line unless you have really diluted it enough. But in a peripheral line, you have to watch out for extravasation and tissue necrosis, which may also be, on the other hand, throwing your patient further. So better given with a central line, and you have to ensure that you're not giving it as a rapid infusion. And then if you're giving our IV calcium gluconate, here you have to ensure that at least it should be a slow bolus for not less than 5 minutes as you're administering your calcium gluconate. This should be accompanied by ensuring that you monitor your patient's ECG because the patient is already symptomatic. So you have to continue monitoring your EKG changes. We are going to health educate this patient about diet restriction, feeds that have a lot of potassium. And then we are also going to health educate them about potassium hyperkalemia and its management. So we have to ensure that we do our laboratory monitoring and it should be timely. Next slide. So it should be timely, and we ensure here that if you've seen that in these patients with electrolyte imbalances, patient may not present with only one electrolyte imbalance, and they will have other physiologies that are causing these electrolyte imbalances. So in so doing, your patient with hyperkalemia, if you're going to transfuse the patient, maybe there is some degree of anemia, and it is part of the treatment, you have to ensure as a nurse that you advocate for freshly donated blood, because all the blood with hemolysis, it will raise your hyperkalemia, and then you'll not be doing anything instead. So you have to evaluate your renal function. So this is a process for giving diuretics to ensure that they eliminate potassium. So you have to ensure that your patient has normal or good renal function. If not, then the worst is to seek for dialysis. So the nebulized salbutamol is also talked about that you'd be giving in doses to help us push back this potassium into the cells. So we shall have to prepare our patients for dialysis in the event that this conventional treatment is not helping us to reduce the hyperkalemia. So we shall have to prepare the patient for dialysis. You have them consent, prepare for dialysis line insertion, and then because this is supposed to be a decision made by you, but again, the patient will have cost implications. So you have to engage them in a discussion. The good thing is that in critical care, we do what we call family conferences, and we notify them about whatever is involved in this, because there is a cost implication for that. However, we are trying to manage and resuscitate a life. So you're going to continue doing a 12-lead EKG for further monitoring, and then you will have to be monitoring your electrolytes to evaluate your treatment. But however, as you're doing your treatment, you may give 1 or 2 doses of IV. When you're giving your treatment, you may need to evaluate the doses of all these other conventional treatments you're giving and monitor exactly what it is giving in terms of outcome, as we are looking at the goals of care that we shall review in the end. So as you continuously monitor your urea and creatinine, and in so doing, in some cases, you may also need to do an ABG. That is in case if your hyperkalemia is brought about by acidosis or any other infectious process within the body. So as a nurse, you must have the qualities or the capacity to take off a good ABG sample, run a good ABG test, and then interpret the results. And then you also do the rest of the other labs, urinalysis and all that. Then the other thing is you need to ensure that you have a strict fluid balance monitoring. So we are giving our patients diuretics. You may dry up the patient, and instead you cause other electrolyte imbalances like sodium hyponatremia. So you need to have a strict balance fluid, and you need to have targets onto what you expect to give out from your patient and the maintenance. This is if the patient is not able to take orally, we have inserted an NG tube, and there is no problem with the gut and absorption rate. So we shall ensure, because it's the best route of fluid, any feeding of fluids. Then if your patient, the GIT route is not efficient, then you'll go in for the IVs to ensure that you don't dry up your patient. So in these IVs, you have to make a good choice of the fluid that you're going to give. Are you going to give an isotonic fluid? Are you going to give a hypertonic fluid? Or you're going to give a hypotonic fluid? So you must have a good chance of a good choice of the fluid that you're going to give this patient. So then the next one, we are looking at the nursing role in a non-specific manner to the rest of the other electrolyte imbalances. So you have this patient has been admitted under you in an emergency or in a critical care perspective. We do not only focus on the treatment of that imbalance in question, the electrolyte imbalance in question. So we have to ensure that the rest of the other care components are ongoing for our patient not to deteriorate in another factor. So when you look at, for us in critical care, you will ensure that your first hugs BID, okay, all the bundles of care should continue. For example, the first hugs BID, the neurocritical care bundle, the VAP bundle. So we've seen this patient in question. If we did not lose this patient, probably the patient was a typical patient for intubation. So you would have to institute all these care bundles to ensure that all this care is given to the patient in a comprehensive manner. So you will have to do weighing of this patient on a daily basis. For a patient where you're losing fluids or you're giving fluids, you have to ensure that you monitor weight of the patient to either tell how much your patient is losing or to help you know how much your patient is gaining in some of the certain other electrolyte imbalances, as we shall see. So this should be done on the same day, and it should be done in the same clothes. So the good thing here is in most of the critical care units, you have beds that can take weight. So you capitalize on that to ensure that you weigh your patient daily, because we know our bodies largely have a bigger fluid volume. So we need to rule out that. And then you will administer pain medication. Most of the electrolyte imbalances cause pain and discomfort, muscle pains and all that. So you need to ensure that you manage pain in these patients, and you do all the rest of the other vital observations as you see them on a critical care chart or in any other setting based on the SOPs of the unit where you work. You have to monitor these vitals half-hourly, hourly, and so on, until your patient stabilizes. So, and then you have to provide intravenous or oral hydration, as I spoke about it earlier. As your patients, you are trying to get rid of the extra electrolytes from the body, patients may also have other losses like diarrhea, maybe they are vomiting, still they are losing fluids from the body. So you have to ensure that you supplement on the fluids such that you don't push your patients into dehydration, which will give you another complication. When we continue, we are looking at electrolytes supplements. As we give IV electrolytes to correct the problems, we are not going to give these doses continuously. We give start doses and then we go for oral. They are better because the GIT will choose what to take in and what to eliminate in the long run. So you have to ensure that immediately you transition your patient to oral as time allows and depending on their presentation. So as a nurse, you should advocate for this. And then you'll have to administer oxygen as required. Some of these electrolyte imbalance can lead to respiratory distress. So as a nurse, you are monitoring your patient by your vitals. The next thing is you have to initiate oxygen supplementation based on the level of your patient's severity. You go through the escalation mechanism. If your patient really is not doing well on nasoprongs, you escalate to MakCHS, you escalate to non-rebreather, escalate to non-invasive CPAP, but then you have to bring your intensivist or anesthesiologist on board and show them the progressive failure for the patient, even where you're giving your oxygen. And then you have to educate the family about these electrolyte abnormalities. The problem could be coming from home, that maybe they don't have enough feeds, or the feeds they have, they don't know how to juggle with them to ensure that they get balanced electrolytes. So you bring the nutritionist on board and then ensure that all this is done. Yes. So as I am, time is against us, I am looking at when the last component of your nursing process, you're looking at evaluation. So you have to evaluate your goals of care. What you set out to achieve at the end of the period that you have set. If you feel you have not achieved them, then there was a problem either in the implementation or in the planning that it was not effective. So you need to sit back and replan and see what you need to do best. Sometimes you have done all what you could in your means, but the patient is not improving. So this is at the point when you should advocate for a referral as you're talking to your physician, your anesthesiologist, or your intensivist, and giving them your side of the story. So as we are trying to conclude, sorry, I may not go through the entire presentation because of time. So the other component I wanted to look out for as a nurse is on management of hypokalemia. So when you look at hypokalemia, the first thing is, of course, you need to know that hypokalemia is a life-threatening problem. You have to assess for the cause. That's where we begin from in assessment. And then you do your lab work, okay, to ensure that you you know where to begin from even when you're doing your correction. You will still continue doing the same lab work for monitoring. So as we are managing hypokalemia, take note if your patient is on digoxin, to ensure that you monitor your digoxin levels. The therapeutic window is between 0.5 to 1.5. As a nurse, when your digoxin levels have reached 2 and above, you know you're going into digoxin toxicity. So you have to ensure that you also monitor that. So you're going to administer the prescribed potassium, but this potassium is a red alert drug. If we refer to crash carts, we all know a crash cart. For those who don't know, these things are usually available on the Google. So potassium IV is a red alert drug, and it should be given with caution. One, it should not be given as an IV push, because it will throw you into a cardiac arrest immediately. So the first thing you're going to do is to ensure that you dilute this potassium, okay? And as you're diluting it, the preference is not to use a peripheral line. But if it's what you have at that moment, we have no choice. You further dilute it as even Dr. Erasmus recommended. And then it is better this potassium is given using an infusion device, because even then you can regulate what you're giving to the patients, where we advise that you shouldn't give more than 10 milliequivalent per hour for this patient, depending on what you want to correct. If it is you're giving calcium chloride, you have to ensure that you're not giving more than 1 milliequivalent. You have to reconstitute it to 1 milliequivalent per 10 ml in your solution, and then you continue your administration. So you have to ensure that you monitor your EKG, okay, as your patient is on your potassium. And then you have, if you are using a peripheral line, you have to monitor for phlebitis and infiltration, because this is very painful and it can cause all those problems. So once any of them sets in, you have to change the line. You have no choice. So as the patient gets the first doses IV, then we shall transit the patient to oral potassium. So when we go to oral potassium, you have to ensure that, one, you watch out for signs. They are very rare, but they could happen. For these kinds of signs of abdominal pain, distension, nausea, vomiting, diarrhea, those are very bad signs that you need to stop the drug immediately and inform your prescriber about what is happening. There is a lot that we need to speak about this drug and hypokalemia, but time cannot allow. Yes. So lastly, let me end on this slide of hypernatremia. As a nurse, you need to continue assessing your patient. You need to do your lab work, as I said, and you need to rule out the cause. In most cases with the hypernatremia, the cause could be maybe the patient lost a lot of fluids, or the patient has you need to, in other words, you need to find out the cause, and then you need to monitor the daily weight for this patient. For example, if the cause was fluid volume loss and you're replacing the fluids, you need to monitor your patient's weight daily. You need to ensure that you have good renal function, okay? And if the cause is inadequate renal excretion of sodium, you have to prepare all diuretics to promote sodium loss for this patient. You are going to restrict fluid intake that contains sodium. You're going to restrict a sodium diet, okay? And then watch out for signs of increased lethargy, spontaneous muscle twitches, irregular muscle contractions, and so on. As a nurse, you are supposed to monitor for all those, and you are going to implement seizure precautions because these patients basically tend to get what we call altered cerebral function. They are agitated, they are aggressive, and in the end, because of the confusion, they get seizures, and sometimes some of them may fail to get a normal GCS post-ictal. So you're going to institute seizure precautions as a nurse. These seizure precautions are well known. You can first, for example, you will ensure that your bed is at the lowest height level. In the event that your patient falls off the bed, you're going to ensure that your side rails are raised and padded. You will give your patient a pillow. You will ensure that your patient is, you administer oxygen, okay, to your patients. You're going to ensure that you have prepared for contingency. You have an intubation tray at the side. You have a mechanical ventilator ready for this patient, just in case you need to intubate them, you need to ventilate them based on their condition, how they present. So that's why this patient is better managed off in a higher level setting than lower level setting, okay? So ensure that you do position changing for this patient, and you do a range of motion exercises in cases where your patient's GC is low and they are really critically ill based on what they are going through. And call the physio team, because as a nurse, you're supposed to be an advocate for your patient. So through your advocacy, kindly call for the physio team to be on board and continue managing the patients. And lastly, on that point, for your patient of hypernatremia, if you really have a refractory situation or a worsening hypernatremia, again, you have to prepare your patient for dialysis. There is no shortcut. Because of time, I would love to end at that point. Thank you very much for listening. Hopefully there will be another time that we can digest quite something else in a very good time stipulated. Thank you very much.
Thank you so much, Mr. Ssemwanga Edrisa, for that excellent presentation on the nursing care. We have appreciated that management of a patient with electrolyte imbalance is it is teamwork. One clinician or one specialist cannot able to take care of that patient. So our time is fast spent, but there are some questions which I've seen in the page, in the chat. Dr. Erasmus has answered most of them, but there is a question which is still unanswered. Someone, Patrick Smakul asked, at what point do we say hyperkalemia is refractory? Yeah, like when do we say this patient needs like dialysis immediately?
So the word refractory hyperkalemia really, for all purposes of operations, refers to inability to eliminate the potassium from the body without extracorporeal use. So you have a patient who has come into you with a severe hyperkalemia. You give them calcium, it helps stabilize the cardiac rhythm, which buys you time. And then you go on to shift it. And for sure you shift it, but remember, shifting is renting space. You're only buying a few minutes, a few hours, while you are preparing for an intervention to eliminate it from the body, which means giving them a diuretic, for example, to get it out. Now, if a patient comes to you with a very severe potassium level, as I mentioned earlier on, the shifting measure only shifts a small amount. And then within a few hours, when the effect of that drug is wearing off, that electron is going to shift back into the bloodstream and re-establish those effects. So by that time, the idea is that if, for example, I gave you salbutamol nebulization, the effect may last about 4 to 6 hours. During that time, I should have optimized the renal loss using maybe Lasix. And remember, Lasix lasts 6 hours. That's why they call it Lasix. So you want to be dosing it every 6 hours. So you want to give a big dose to induce a significant diuretic effect. If the patient is diuresing too much and you worry about that, it means that they're losing potassium. So what you do is optimize the volume by replacing the volume they're losing so they don't get hypovolemic, because that's the main concern. If you give a patient a good dose of Lasix, let's say you give them 240 milligrams of Lasix, and there's barely any loss of urine, it means for sure you're not going to win this battle by medical management. That has already become refractory. It means you cannot be using your shifting measures to buy you time to reach a dialysis unit. If, however, the patient starts to pee when you're given a large dose, the next question is, are they having refractory arrhythmias despite you loading them with a lot of calcium, and you need to be doing it all the time? It means that whereas diuresing them might work, the problem is that it might take time. And its potassium is so high that in between you're getting so much instability and the patient could die. So the quickest way to get them out of danger might be take them for dialysis as an adjunct to the correction. In fact, you should be excited the patient is able to diurese. It means that this patient might not remain in that state for a very long time. So give them a diuretic, shift them, continue giving calcium, and then go to dialysis. Dialysis clears out a big chunk of the potassium, which lowers the serum levels to levels are acceptable, which might be able to sustain medically. Let me give you an example. I've received a patient with a potassium of about 9.8. Okay, his heart rate was about 25. And the cause was this guy had been on telmisartan and so on. Now, remember, patients with chronic disease are very, very, they're very respectful of their health workers. The doctors, we have a habit of blaming patients when they come to us that they are not adherent. The patient is not getting worse, you tell them it's because I'm not adherent to their medication. So these guys will continue taking their medication if they're not drinking enough, even if they are having an infection, even if their kidney function is declining. Because you've told them to come for review after 3 to 6 months, they'll not come earlier. So during that time, the drug now is causing side effects in the patient. So by the time this guy turned up because he collapsed. He had multiple syncopal events. He's lucky not to have gotten a cardiac arrest, but that's exactly how it presented. So we go on treating it, and he was responsive. Kidneys could respond to a good dose of diuretic. So we gave him a loop diuretic. We gave him a proximal tubular blocker, that is acetazolamide. The idea is we want to increase the amount of sodium that reaches the distal tubule. The higher the sodium delivery to the distal tubule, the higher the potassium loss, because the distal tubule will reabsorb so much of the sodium. So that's what we try to do. And for sure, the man was diuresing well. The problem was that the potassium was way too high, such that even if we're losing the potassium, I'm sure it was dropping 9.8 to 9.5, 9.1, so that is still extremely high, and was having arrhythmias. So ultimately, we had to put him on dialysis while we continued the elimination and shifting. And after about 2, okay, it was a CRRT that we did for him, that's continuous renal therapy. We dialyzed him for about 48 hours. Once we stopped dialysis, the potassium had dropped about to 7.5. Remember, that's with dialysis. Remember, the effect of these drugs stays and persists as long as the patient has renal function. These are long-acting drugs, and because of declined renal function, the drug has not been accumulating in the body. So while it was 7.5, it was still a bit unstable, but a lot more stable than before. So we continued now with medical management, stop the offending agents, continue diuresis, and slowly the guy got better. Heart rate kept increasing. It was quite a classic thing to see. Heart rate came from 25, going up gradually until eventually he was able to leave the hospital.
Thank you so much, Dr. Erasmus. for that excellent reply on that question. Our time is really fast spent. I know the audience would have loved to ask some questions, but we may not be able to allow that for now. Allow me to welcome each of the experts who will give us just a take home in 30 seconds. Let me start with Mr. Ssemwanga Edrisa. What's the take home message for the audience about the nursing bit of the patient with electrolyte imbalance?
Thank you very much. The take home here is, as nurses, we have to know that electrolyte imbalances should be really taken as an emergency, because your patient can easily deteriorate in the shortest period of time possible. So you have to calculate whatever you're going to do for your patient. You have to be sure about what you're going to do. If you are not sure, there is no time to joke around. There is no time to guess what you have to do. So refer the patient to the right people to ensure that we manage the patient very well. And you have to ensure that every drug you're going to give to this patient who is having electrolyte imbalance to collect electrolytes, you have to know exactly how to conduct the administration of the drug. Any slight mistake will cause loss of the patient or loss of life, or will throw your patient further away from recovery. So if you are not sure, you have to seek for help from people who are experienced and who know. So basically, that is the take home, but people should ensure and know that this is teamwork. It is not an individual's role, it is teamwork. Thank you very much for inviting me to the.
Thank you so much, Mr. Ssemwanga Edrisa, for that. For delivering the take-home message about the nursing for patients with electrolyte imbalance. Let's have Dr. Mwirumubi give us a take-home message for the audience of electrolyte imbalances.
Thank you very much, Chair. I don't have a lot, but I should tell the audience that electrolyte imbalance management is a multidisciplinary approach, and following our ABCD approach should always make sure that you stabilize the patient as soon as possible, and then go ahead to make sure you link up the patient to where they're supposed to get specialized care from. I think that is the approach I would recommend. And then, importantly, the 5 A's that Dr. Erasmus has talked about, very important to note. And I think that would be the best approach for us to go on and adapt in emergency care settings. With those few remarks, I think I would like to thank you for inviting me to this session.
Thank you so much, Dr. David, for delivering your take-home message. Finally, let's have Dr. Erasmus Okello give his take-home message to the audience. Welcome, Doctor.
Thank you very much for having me. Always beautiful to share. I learn a lot. From an early age, I'm a very old man. I learned better when I share. And it's always a sweet moment for me to share what I've learned over time and recall a lot more. So this has been a beautiful experience. The bad news is that we are all going to die. And the reality is that electrolytes are going to be a major part of that process. Every disease tries to kill us through electrolytes somehow. The bad news again is that electrolytes mess up with all of us. And I promise you that senior consultant, that professor, that person with very many titles struggles when electrolytes are the problem with the patient before them. So you're not alone. But through sharing these experiences, we get better, increasingly better. There's a lot that's not known. But my hope is that through sharing like this, we all get better. Again, as mentioned, very non-specific presentation, and yet there are ubiquitous complications of so many problems. It just means that for every patient you get before you, think electrolytes, think they could try to kill your patient, think they could complicate your treatment, think they could prolong the patient's stay, think they could embarrass you as a health worker. You're thinking about discharging a patient and they stand up, walk the door and collapse and die. You're the one who has failed, that's what they'll say. So develop a deep respect for electrolytes, not just in your own health and life, but also in your medical practice. And that's the only way you will understand. You have to monitor them very closely. You have to treat them with a lot of respect and save lives. I wish you all the very best in your career as health workers. And hopefully we shall get to share a lot more. Thank you.
Oh, thank you so much, Dr. Erasmus Okello. And I want to use this opportunity to thank all the presenters for the presentations. We have learned a lot, and many of us, we have been inspired to go back to school because I realized that the gap is really big. We need to polish our knowledge much more as far as patient care is concerned. So thank you so much, the audience, for attending. Allow me close the session. Or let's first have a screenshot, and then.
Thank you, Dr. Erasmus.
Yes, please, I request that we put on our videos. We take a screenshot. I request we put on our videos kindly, so that we can take screenshots.
I think the host disabled the videos, so the host should enable the videos.
Yeah, it must be your network. Probably like.
I think they are on. Videos are on. We are seeing some people here.
Yes, videos are on.
Yes.
He's using Leica.
Okay. Thank you so much. Thank you so much for attending. Yeah. We shall be glad to inform you about the next session. Yeah. Thank you so much for attending.
Thank you, Jim. Can see Calvin, Mark. Thank you for coming. Today we appreciate you, and we know that there's still a big struggle on how to navigate the IECO platform. We shall find an easier way to enable our participants to go to the session. Thank you all.
No. True, that's true.